Hello, everyone, and welcome to this evening's webinar on traumatic dental injuries. My name's Hannah-Laura van Velzen, and I'm the Dentistry, Oral and Maxillofacial Surgery Registrar here at Fitzpatrick Referrals. We're a pretty new department here, so most of you probably know Fitzpatrick for their orthopedics and their fantastic neurology department. Our Dentistry and Maxillofacial team launched in January of this year. And I hadn't meant to look up how many patients we've seen so far, so you'll have to forgive me for the little blank, blank, blank there. But it has been quite a whirlwind. We've had loads and loads of different patients, from the very, very small to the very, very large, all different kinds of ages and all kinds of different dental conditions and maxillofacial conditions. And that's included working together with the other departments on some really interesting cases as well. We're a smaller team. There's three of us in our team, but as they say, teamwork makes the dream work. There's myself. I'm the head of our dentistry service, and I started here having completed my EVDC residency at Eastcote Referrals in Swindon, and I'm currently in the process of sitting my diplomat exams. I'm joined by our fantastic dental nurse, Jessica Skates, who we've managed to nab from one of the other referral centres, and Jessica has a really, really extensive knowledge of anaesthesia and is therefore able to tailor each of our anaesthetics to our individual patients depending on their needs. And that can vary from some of the patients that come for more routine dentistry stuff but have really complicated anaesthetic needs. But even just our general patient base will vary from really, really young patients, so around kind of 4 months old, all the way up to those really, really ancient old patients that have multiple comorbidities. So we really wouldn't be anywhere without a fantastic nurse taking care of them on the other side. And then to complete that team, we are really, really lucky to have Lindsay Hudson. Not only is she our dedicated veterinary care assistant, she's also recently completed her RPS certification, so she's the one keeping an eye on me when I'm taking my x-rays. And she brings with her a wealth of experience from her 22 years on human dentistry side, and kind of brings the whole circle round in that way. So we really get to work together as a team for each of our patients and make their stay and their treatment as good as we possibly can. But we're here today to talk specifically about traumatic dental injuries. And I guess the first question we can always ask ourselves with these kind of webinars is, why are we here this evening? And why is it so important that we talk and learn more about what we would call TDIs, traumatic dental injuries? And the really simple answer to that is that they are really, really, really common. So it's estimated that about 14 to 27% of all dogs and cats have at least one traumatic dental injury type in their mouth at any given time. The 14% is from slightly older studies, up to 27% is slightly newer studies. So probably around a quarter of the patients that you're seeing on a day-to-day basis. And there's a good amount of those that are probably going to need some sort of intervention or treatment. But if we look at specific subtypes of animals, and particularly our working dogs, so dogs that are using those teeth for bite work and using them for a lot of day-to-day activities, we see that the incidence of dental injuries increases massively in those. And a whopping 60% of those dental injuries have exposure of the pulp and therefore are going to need some sort of intervention, whether that be endodontic treatment or extractions. But unfortunately, we don't pick these things up as often as we really should. Obviously, for my kind of trained eye, dentistry is all I look at, so I miss all the other stuff. But I'm really interested in teeth, and I've seen so many teeth in such a long time that I almost notice something is out of place first before I really realize exactly what is wrong. And that we see in kind of all dentistry specialists and residents. There was an interesting study done where they looked at the amount of TDIs present in cats and dogs that were presenting with maxillofacial injuries. And one of the things they did in that study was they compared the percentage of TDIs that were identified in those patients when those patients were looked at by a dental specialist or resident versus any other clinician in the building. So ultimately, the percentage of TDIs in dogs and cats presenting with maxillofacial injuries is about 72%, so nearly 3/4 of patients. And it's, it's logical that we might not miss those if we're not looking for them, because we get distracted by all of the other trauma that's going on. There might be ocular trauma. There's blood coming out of the nose. The jaw is hanging in a weird angle. And it's really obvious that that is really distracting, because when they looked at the percentage of TBIs that were picked up by other clinicians, like our out of hours or our emergency critical care, they only diagnosed 6% of those animals with maxillofacial injuries having some sort of TDI. And that's really disappointing, because yes, we need to fix those big problems that are there, because they're the kind of really acute things that are causing the animal the most pain. But also, the overall goal is to send that patient home at the end of the day in a really comfortable way and back to normal health. And if we're missing diagnosis on things, then we can't treat them, we can't address them, and we're potentially sending our patients home with pain that we could have actually been treating. But I'm not here to slap anyone on the fingers. We're here to learn together and kind of figure out what we need to be looking at, what we need to be advising, what we need to be doing, and what options we have as well. Before we really dive into it and really sink our teeth into it, as it were, I'm just going to bring us back to some really, really basic dental anatomy and some concepts that will be really important to understand when we're talking about which type of treatments are relevant for which kind of injuries. The first is just a little bit of basic dental anatomy. So each tooth is placed within a socket and generally consists of two portions. There's the portion above the gum line, which is termed the crown, and there's the portion under the gum line, which is the root. When we look at the bulk structure of the tooth, they will consist of generally three materials. The inner portion of the tooth is the pulp, so that contains the nerves and the blood supply. But a really important part of that pulp is a layer of cells that lines the chamber or the canal that the pulp lies in, or the pulp canal. And that layer of cells is called the layer of odontoblasts. And odontoblasts are the cells that are creating the main structure of the tooth. And that hard structure that they create is called the dentine, and that's the main bulk structure of the tooth. And they continue this throughout the life of the animal and throughout our life as well. And then last but not least, there is a layer of enamel that covers the surface of the tooth where the tooth protrudes above the gingival line. And this is where we can see a really interesting difference between human teeth and animal teeth. So for us humans, our teeth are designed for grinding motions. It's expected there's going to be a lot of wear and tear through our lifetime. So our layer of enamel is quite thick, several millimeters, so that it takes a really long time for us to really wear through all of that before we get into the bulk structure of the tooth, which is the dentine. And the reason that we need that protection is because that layer of odontoblasts, as they're building the dentine, they leave little tubular structures open in the dentine and have little finger-like projections that go through that. And if you've ever chipped a tooth and exposed a bit of that dentine, you felt that your tooth becomes sensitive. And that's the exposure of those little finger-like projections to the outside world. And the enamel is protection against that. But in our animal patients, our teeth aren't designed for chewing and grinding, or at least not in dogs and cats. They're designed for piercing and cutting food into small chunks so that they can then swallow it. And their enamel, therefore, is extremely thin. So for dogs, we're talking probably about 0.5 millimeter to maximum 1 millimeter thick. Whereas in cats, most of the time, we're talking even less than 0.5 millimeter. So it's a really, really, really thin layer. It's just providing a little bit of protection. It's really not providing a lot of protection against things like wear or fractures, not in the same way that we have it with our teeth, where it's much, much thicker. The tooth itself is then supported within the socket by something that we call the periodontium. And the periodontium consists of 4 different structures that help kind of lodge that tooth within the socket. The root itself is coated by another mineralized layer, which is called cementum. And this is what the periodontal ligaments attach into. The periodontal ligament space has lots of fibroblasts in it. They're constantly breaking down and rebuilding those ligaments. And the ligament itself acts as a kind of shock absorber. It not only holds the tooth in place, but it also allows us to do things like biting and chewing. And it allows micro movements of the tooth without that immediately causing pain, because it would be completely set within the bone. On the other side, it's then anchored into the specific type of bone, which we call the alveolar bone. The alveolus is another word for tooth socket. And then finally, that space itself, so the periodontal ligament space that has the alveolar bone, the cementum, and the periodontal ligament, is sealed off from the outside world by the gingiva, and specifically by a portion of the gingiva called the junctional epithelium, which is at the bottom of the gingival sulcus, and allows some permeation of things like white blood cells and a little bit of fluid, but generally is trying to protect against the invasion of bacteria into the deeper tissues. Another important concept to understand is the fact that teeth are developing through life. They're not static subjects. And we can see this very well if we look at a series of x-rays throughout the life of an animal. And this is not the same animal. They're all very small dogs. So that's where I've started. This is a 4.5-month-old, not so small dog, Clumber Spaniel, this one. And you can see that she is in the process of changing over her teeth. So we can see some deciduous teeth there, which are those really long, thin-rooted ones. But the big thing that we can see there developing under the surface are the big mandibular canines. And I often say to owners, teeth develop from the crown down. The crown is the first thing to develop under the surface. And then those odontoblasts are creating the dentine to form the root. And they start at the top and they sort of work their way down. As time goes by, so this is an 8-month-old Yorkshire Terrier, that creation of more and more root structure is part of what helps push the tooth and erupt the tooth out of the socket. And we can see in this dog, we have a fully formed crown, the teeth have erupted, the deciduous teeth have gone. We've got quite a big part of the root structure and the root walls, but what we don't have is the apex, or the end of the root. There's what we call an open apex. So there's a very wide opening at the bottom of the tooth through which the blood supply and nerve supply is coming into that tooth. This is a 1-and-a-bit-year-old Yorkshire Terrier again, and we can see that at this stage we have the full root formed. We've got a full apex, and if you paid attention to the width of the pulp canal, particularly in the crown of the tooth, it has gotten thinner and thinner with time. And this continues through life, so that those odontoblasts don't stop once the tooth is fully formed. They're going to keep making dentine throughout life. This is a 10-year-old Yorkshire Terrier. You can tell it's a Yorkshire Terrier because it's missing quite a few of its teeth by now and has quite a bit of periodontal disease. But you can see just how thin and spindly those pulp chambers are on these teeth. So again, we've got a full tooth, it's erupted. Not much has changed there in the positioning of the tooth, but we can tell that this tooth has continued its development as we would have expected for a 10-year-old dog. And left and right is also pretty symmetrical. So coming into our traumatic dental injuries, when we think about trauma, I think one of the things we often think about first is fractures, because those are the more obvious ones. But there is quite an extension of different traumatic injuries that can occur to a tooth. And this is a little overview from a human book written by Andreasen of all the different types that we can have. And generally, the easiest way I find to split these two up is into injuries to the supporting structures of the tooth, so to the periodontium, and injuries to the tooth itself, so to that bulk structure of the tooth, so the enamel, the dentine, and the root structure of the tooth, plus minus pulp. So if we start with those injuries of the supportive structures, we're going to work our way up. We're going to start with minor injuries and work our way up to the bigger injuries. So the least aggressive of the traumatic dental injuries that we can have is called a concussion. So this is when a tooth gets knocked, similar to when we have a brain concussion. And in this case, that knock as a reaction and a response causes swelling and some bleeding within the periodontal ligament space. However, and sometimes, but not always, some damage to the neurovascular supply to the tooth itself. The symptoms are very, very minimal. So in humans, people often describe that if someone taps on their tooth, so percusses the tooth, that's quite painful. And that's because as we're tapping on the tooth, we're actually creating a vibration within that periodontal ligament, and that thing is swollen and bleeding and painful. And there are a lot of nerves in the periodontal ligament space, and they will then make that percussion painful. But otherwise, there's not really anything to see on the outside. Luckily, no treatment really specifically is indicated. And that's a good thing, because this is one of those things that'd be really, really difficult to diagnose in our dog and cat patients. They're really, really good at hiding pain. They're certainly not going to come and say, oh, when you touch this tooth, it hurts. What they do say in human medicine is that they recommend monitoring of pulpal vitality up to about a year afterwards. And that's because there is the potential that we can have damage to the neurovascular supply to the tooth. And if that damage doesn't heal well or doesn't heal at all, then that will mean that the odontoblasts that are due to kind of maintain and take care of the live portion of the tooth will die, and the tooth will stop developing. The rest of the pulp within the tooth will eventually then become necrotic, and that will then eventually lead to periapical disease and pain and inflammation in the bone. And this is what that can look like on a radiograph. So this is an X-ray of a left mandibular third and fourth premolar in a dog. And we can see from the fourth premolar and that little bit of the second premolar on the left, that in this dog, that would be the thinness of root canal that we would expect. But when we look at the third premolar, the pulp chamber there is a lot wider. And that's an indication that that tooth died quite a while ago. But if we look at the tooth itself, there's really nothing wrong with that tooth. It's missing a tiny little bit of enamel, but really otherwise, it's not really got any significant periodontal disease. It's not got a significant fracture. It is possible that this tooth underwent a concussion. We'll never know. But something happened to this tooth, probably some sort of blunt force trauma, and as a result, it's become necrotic and died. The next step up from a concussion is something that we call a subluxation. And in this case, we very much have similar signs to the concussion, but we've taken a little step further. So instead of just having swelling and bleeding of the periodontal ligament, we now also start to see tearing of the of the periodontal ligament structures. And in this case, there's no question about damage to the neurovascular supply. There will be damage, but that doesn't necessarily mean that the entire neurovascular supply is gone. It can be partially torn, which might mean that it can regenerate with time, or that enough neurovascular supply might be left for that tooth to maintain its vitality. Unfortunately, I could not find a good picture in my set of books for this in dog or cat patients, but I've had to add a really disgusting human mouth in here. Humans are gross. And in this case, really the one symptom that we would see is a little bit of bleeding from the gingival sulcus. And when that tooth is examined, increased mobility of the tooth. And that's because part of the periodontal ligament has been torn. But if we look at the tooth from the front and from the bottom up, we can see that the positioning of that tooth hasn't changed. So we've just moved it a bit. We've gotten a bit of tearing of the periodontal ligament, a bit of bleeding as a result, but otherwise the tooth has not changed in its overall position. And the treatment here is more supportive. So it's a little bit more than just monitoring it, ideally, but it's also not particularly invasive. So we just want to prevent putting a lot of movement and mobility on that tooth, so that we're giving the periodontal ligament time to heal. So they'll often recommend that people just eat a soft diet for about 2 weeks, or if the mobility is just a little bit more severe, they might create a little splint where they connect that tooth to some of the teeth next to it, just to help hold it in place in the few weeks that it takes that periodontal ligament to regenerate itself and anchor the tooth back into the right place. Again, in humans, they recommend monitoring for that pulpal vitality in case there has been a total rupture of the neurovascular supply. This is where it starts to get interesting for us veterinarians, because we're going to start seeing things now that we will obviously see in practice, because the next step up is a full luxation of the tooth. And we see 3 different types depending on the direction that the tooth has moved in. So in this case, the tooth will have not come out of the socket entirely, but it's also not sitting in the same place. It has been moved physically. We see extrusive luxation. That's when the tooth has been pulled out of the socket, so kind of in a coronal direction. Intrusive, which is when the tooth has been pushed into the socket. So that's when we push it into an apical direction. And a really good example of those are dogs that have either fallen and they've fallen onto their face, or they've been kicked by something in the face, say a horse or a deer. And someone might think, oh, that tooth has disappeared. Maybe it's fallen out. Sometimes, especially incisors, they get kicked hard enough, you can have intrusive luxation and those teeth can get displaced right up into the nasal cavity. So it's always important to image teeth that have disappeared after a traumatic event, just in case there's intrusive luxation or part of the tooth is fractured and there's a root remaining there. And the one that people are probably a little bit more familiar with would be our lateral luxation. This is a little spaniel that we had in earlier this year called Aspen, and she is a classic case of lateral luxation. She had managed to do it with both of her mandibular canine teeth. We don't quite know how. Other stories that I've had are dogs trying to catch something, getting their tooth stuck in a fence and then pulling it and yanking it to the side. So there's maxillary canines that suddenly stick out at a weird angle. And basically in those cases, what we see is that the tooth it's partially come out of the socket. It's not completely come out of the socket or completely out of the mouth. And these type of movements, so the lateral luxation is almost always associated with a fracture of the alveolar bone. So part of the bone that is attached to the higher portion of the root comes away with the tooth as that tooth is forcefully moved from the socket. Now, obviously, this means that we've not just had a little bit of tearing of the periodontal ligament, we've had quite extensive disruption because the whole tooth as a whole has moved, so all the ligaments have been torn, and there's no way that this neurovascular supply at the apex of that tooth is going to be intact. That is going to be ruptured as well. And that's important to realize for our treatment. And because of these things, luxation is one of those rare true dental emergencies that we see. We don't have a lot of them, but a lot of them are going to come up in this. And I say emergency if the owner is adamant they want to preserve the tooth. If they don't want to preserve the tooth, it doesn't matter if I treat it now or tomorrow. But if they want to preserve the tooth, the sooner we see it, the better the prognosis is going to be. The lateral and extrusive luxation get treated in a reasonably similar way because lateral luxation is also a kind of extrusive luxation, just the tooth is also moved to the side and often associated with an alveolar bone fragment. So the first thing we want to do is try and reposition the tooth within the socket, which can sometimes take quite a lot of force to achieve. And ideally, we want to do this within 24 hours after the tooth was luxated. And that's because, not necessarily because the tooth isn't getting a neurovascular supply, because that's gone, but the periodontal ligament base that contains all those fibroblasts has been disrupted. And the sooner we can get that space back to normal and healing and getting sealed off from the outside world, the less chance of infection we're going to have, and the more able the fibroblasts are going to be able to regenerate the periodontal ligament. And also, the longer the ligament itself is torn and not in the right position, the more of those structures are damaged, which will be more over time, the more of an inflammatory response we'll get when that cleanup and healing starts. And quite significant inflammation is associated with more complications down the road. So these guys, we want to see them pretty soon. Once we put that tooth back in the socket, what we want is for it to stay there. So we'll suture up any soft tissue wounds, because often if that's, especially with lateral luxation, if the bone is broken under it, it normally has a soft tissue tear as well. So once we've got that tooth back where we want it and we've confirmed that with X-ray, we then suture up the soft tissues around it, and then we can apply what we call a non-rigid splint for 2 to 4 weeks, depending on if it's lateral or extrusive luxation. Whether or not we treat the pulp problem depends on the age of the tooth. So where I said that neurovascular supply has been completely ripped away, the pulp now has no blood supply, it has no nutrition, and the odontoblasts within are likely to die. However, if we think back to those pictures of the teeth that were maturing, an immature tooth has a really big open hole at the bottom because it doesn't have an apex. So if we can reposition that, it's in pretty direct contact with the kind of periapical bone and periodontal ligament space that's exactly around that apex. And that happens to be a reservoir for a specific type of stem cells. So immature teeth actually have quite a high potential to revascularize themselves. It doesn't mean they always do it, but there is a good chance that they will. So if we can get those teeth back into the right position as quickly as possible, we may not have to do any kind of endodontic treatment on that tooth. It may well just continue to develop in a normal way once it's been stabilized. For mature teeth, however, that have that complete apex formed, the only connection they have with the rest of the body is through the apical delta. So they have lots of little tiny perforations at the bottom of the tooth root, and all of those little vascularizations go through there. So it's a lot harder for things like stem cells to get inside the tooth to create that revascularization and allow that to happen. So the prognosis for mature teeth to revascularize themselves is really, really poor. And therefore, we would always recommend root canal treatment for those teeth to prevent us getting complications from pulp necrosis later down the line. And this is a nice example. This is a dog that I saw a few years back, actually. She was a little miniature dachshund called Daisy, and Daisy had, unfortunately, not through her own, even though she was a Dachshund, she wasn't that kind of Dachshund, but another dog had taken, with a bad mood, had taken a dislike to her and bitten her in the bottom jaw and luxated her lower right canine, so her 404. And you can see the soft tissue injury that we've sutured up, kind of running from left to right, just behind the canines there. And once we have that tooth back in place, we've placed this lovely little splint. So this is a type of interdental wiring that we can perform called a modified scalp loop. And then we covered that splint with something called bisacrylic, which is or a temporary crown material. And basically the wire is helping to keep everything in the right place. And then the bisacrylic is adding rigidity to the splint. But there is some mobility allowed there. So we call this a non-rigid splint. It's quite rigid, but it does allow for a little bit of movement, which is really good for things like periodontal healing. And one of the things that we did there as well is constantly checking that she could close her mouth well. So we were checking that the alignment of the canines is exactly the way we want it to be, and also that the splint isn't too bulky. And the vast majority of dogs and cats will tolerate these intraoral splints really, really well. It takes them maybe half a day to get used to it. And the only downside really of them is that over time they do accumulate a lot of food and plaque, so they do get quite smelly. So that's just something to warn owners of. But overall, because we design it in a way where they can open and close their mouth without the splint getting in the way, they tolerate it really well. They can eat really well past it, and we can leave that on for as long as necessary. So this is also something that we use a lot for different jaw fractures. So this is the immediate post-op x-ray. So you can see that we've replaced the tooth within the socket, and you can see how nicely that brings the fracture edges back together actually in her. And that's really commonly the case because you're kind of using that canine tooth or whichever tooth is luxated almost as a guide to bring those two fracture lines back. And you can see where we put the wiring on, and you can just about see the acrylic there as well. This is, unfortunately, I wanted her to come back a little bit sooner, but due to personal circumstances of the owner, they couldn't come back till quite a few weeks after I'd wanted them to. And we can see here the consequences of that dead pulp that's inside the tooth. So where the pulp has necrosed and died off, it has now sat there in the tooth and it's started to leak necrotic products through that apical delta into the surrounding bone. And not only have we developed a periapical lesion there, so that blackish round circle around the end of the root, there's also a lot of inflammation associated with this. And we can see that because quite a lot of the root tip has been eaten away. And that's the body's way of trying to clear up that infection. So we couldn't perform a standard root canal on her. We performed something called an MTA plug. So I put a different material down there, which then hardens, and then I can backfill for the root canal. That's what she looked like when she came back for her 6-month check after her root canal. And we can see that there's been a really nice resolution of that periapical lesion. All of that's filled back in with bone now. and there's been no further progression of the tooth resorption. So she's healed really well. We can see on that X-ray and the one when she came back that the fracture line has completely resolved as well. So she was a really nice outcome, despite having a minor complication there as well. Intrusive tooth luxation has to be treated slightly differently. If it's very severe, so those incisors I was talking about that get displaced into the nasal cavity, we often can't do anything about those. But if it's only partially intruded into the tooth, then there are ways for us to bring the tooth back into its normal alignment. And again, exactly how we do that depends on the age of the tooth. And that's because in immature teeth, as I said before, we've got those odontoblasts that are still building up and creating the root. And in doing so, they create a force that pushes the tooth out of the socket into its normal eruption position anyway. So we can make use of that. And because of that, some of these intrusive luxations may well just spontaneously reposition themselves just because they are already erupting. Sometimes they need a little bit of assistance with that. If they've been pushed inwards in a way that they're quite wedged into the bone, we might have to just use a forceps to loosen them slightly, but then we can let that eruption force do the rest of the work. If that doesn't work, then we can create an orthodontic device, almost like a little pair of braces, that will put a very light force on that tooth and slowly pull it into the right position over the course of about 2 to 3 weeks. And again, the prognosis for these teeth is actually quite good because they're immature and they're quite likely to revascularize on their own. For mature teeth, they don't have that eruption potential, so they do need a little bit more help. So we can either do something called surgical luxation, which is just a fancy way of saying we pull them into the right place and then we fixate them there for a while, or orthodontic extrusion, which is very similar to the way we would do that in an immature tooth that hasn't spontaneously repositioned. But these teeth are unlikely to revascularize and therefore will require root canal treatment as well. Intrusive tooth luxation, of the different types of luxation, even though the lateral luxation looks extremely traumatic, intrusive tooth luxation is probably the more traumatic injury to the tooth and the surrounding structures. And that's because we get that compression of the periodontal ligament and the alveolar bone and the cementum. We get lots and lots of inflammation in that area. There's a lot of damaged structures that first need to be cleared out and resorbed before new structures can be created. And because of that, the success rate is really only about 50%. And that's because even though we can get the tooth back into the right position, we very often face complications, including ankylosis. So that's where the periodontal ligament cannot regenerate and the tooth fuses directly onto the bone. Just general infection, because where the tooth has been pushed in, the gingival sulcus and that junctional epithelium will have been pulled along and torn. So bacteria can get in there, and the immune system at that point, which would normally be present in the periodontal ligament space, is initially damaged and maybe can't get on top of that infection, or tooth resorption secondary to inflammation are really, really common in these teeth. And that might mean that we lose them in the long term anyway. So that's a good thing to be aware of. That brings us to the most destructive injury of the supportive structures. So as I said, luxation is a partial movement of the tooth out of the socket, but avulsion is a complete movement of the tooth out of the socket. So in this case, the tooth has been completely ripped out and is now loose on the floor. And this, if the owner wants to keep the tooth, constitutes another true dental emergency in a way that it's more emergent than the luxation one. And this is because the tooth is now outside of the mouth, and the periodontal ligament that is still on the root surface and the fibroblasts that are still on the root surface are now prone to drying out and will die very, very quickly. So ideally, we want to get that tooth back where it's supposed to be within 60 minutes. Now, that's completely unrealistic in veterinary medicine, because by the time an owner has gotten to you, called you, and then gotten to me, and I've anesthetized it, we're way past the 60 minutes. But luckily, there are things that we can do to try and prolong the amount of time that we have. So we can go up to about 3 hours if we can put that tooth into an appropriate storage medium. And this helps preserve the periodontal ligament and the fibroblast and keeps them from drying out and becoming necrotic. The options are fun. There's always new studies going on about these, but the general consensus at the moment is that low-fat milk or semi-skimmed milk is a really good option that most people have in their house, or it's very easy to come by. Egg white is another very good one. Oral rehydration solution, those sachets. Some people might have those in their house, or if the owners are at your practice, just normal physiological saline. And you want to place the tooth within this medium within 15 minutes after it fell out. And that's why a lot of those studies focus on things that owners will hopefully have in their house very easily. It's important to advise owners, or if you're doing it yourself, to advise them to avoid touching the root of the tooth as much as possible. And that's because we don't want to damage those fibroblasts and periodontal ligament cells more than they already are. Then when they do get to us, assuming they've come to us in time and they're really adamant they want to preserve that tooth, then the treatment that we will perform is a very gentle rinsing and cleaning of the surface of the root, repositioning of the tooth within the socket, and then just like with the luxation, glinting it in place. With these cases, we take a little bit, we won't do endodontic treatment at the same time. You would have noticed that I didn't do endodontic treatment at the time I saw Daisy, but if she'd come back when she was supposed to, I would have done part of the endodontic treatment at her first procedure. So she's a bit of a side note. But with these ones, once we've got that tooth back in place, we ideally don't want to move it around too much anymore. So we would delay endodontic treatment till about 7 to 10 days, up to 2 weeks after we've reimplanted and splinted the tooth. Yeah, so that was all of the supportive structure injuries that we can see. So some of them we can't easily recognize in animals. Some of them just need a little bit of monitoring. But we already saw 2 of our true dental emergencies in there. So the next portion of the tooth to talk about is the tooth itself. And this is where we talk about fractures. There is a classification of different types of fractures that is really commonly used, which was created by the American Veterinary Dental College. And this ranges from very, very minimal little cracks called enamel infarction fractions, all the way up to fractures that involve the pulp space and or the root. So if we look at our top left one, that is generally what an enamel infraction will look like. Although they are added on this tooth fracture classification, they aren't considered anything that needs treatment. Generally, if you go over them with your sharp explorer, you won't feel catching of your sharp explorer at all. They are basically indications that the tooth has been bent slightly, and that's called these micro fissures within the enamel. And really, it's an indication that that tooth is being pulled very hard in a direction that it's not really designed for. So it's really common in dogs that really enjoy tug games, that really enjoy pulling things out of the ground, or pulling on their lead with their mouth. Those are the ones where you might see this, or dogs that are doing active bite work as well, because where they bite down, they then also pull and shake the sleeves and things. So if you do see them, especially if they're quite severe, it can sometimes be worth just highlighting it to the owner and trying to minimize those type of behaviors, because they are clearly causing some sort of damage to the tooth, and potentially those teeth might be at a higher risk of fracture just due to the type of behaviors that the dog is showing. The next step up from that is an enamel fracture, so that's the EF there. But because the enamel of dogs and cats is so incredibly thin, it would be really rare to see a fracture that would just be the enamel layer and doesn't involve the dentine as well. So really the majority of the fractures that we talk about are what we would term enamel dentine fractures. So they go through the enamel and through the dentine, plus minus the pulp. So our first type of fracture is one that historically has been termed not particularly interesting, and it's called the uncomplicated crown fracture. And by uncomplicated, we mean that it's not entering the pulp space. And because it doesn't enter the pulp space, historically, we've always seen it as something not to worry about. However, it's really important that we do actually x-ray these teeth when we see them. And this is my favorite example of it. This is a cockapoo called Bart, who came in for a completely different reason. And while I was doing my dental examination of his mouth, I identified this tiny little uncomplicated fracture on the tip of his bottom left canine. And because I was a resident at the time and I was being really thorough, as residents are, because you've got your supervisor looking over your shoulder, I took an x-ray of this tooth. And lo and behold, this tooth had the most horrendous periapical lesion with inflammation and resorption of the apex. And this is the better x-ray that I had. I've already inserted my root canal file at this point because the owners were quite adamant they wanted to preserve this tooth. So we did do root canal treatment on this and it has been successful. But to back this kind of thing up, there was a study done a few years ago where they looked at specifically maxillary fourth premolars, so the upper carnassial teeth that had uncomplicated crown fractures, and x-rayed those, and they found that almost 25% of those teeth had radiographic evidence of endodontic disease. Now, even the people that wrote the paper and dentistry community agree it's probably not as high as 25% in the general population. However, it just highlights that it is really important that we don't take these kind of uncomplicated fractures for granted. And it may well not be the fracture itself that has caused problems with the pulp and death of the pulp. But we need to remember that this tooth has fractured because it's undergone some sort of blunt force and some sort of trauma, and the trauma itself can cause damage to the pulp. So that's why it's really important that we don't treat these as something that we don't have to worry about. If the fracture is really recent, then we can offer to smooth out any sharp edges and apply a dental sealant. So those odontoblasts, they've got their little finger-like projections into the dentine. The dentine is quite tubular, and if the fracture is very recent, that surface of the tooth might be quite sensitive. And hypothetically, those tubules are an opening through which bacteria could potentially get into the tooth. And by sealing that off with something like an unfilled resin sealer, we can both remove that direct sensitivity of the tooth, make patients more comfortable, but we are also kind of completely stopping that potential entrance of bacteria. Eventually, the odontoblasts will have time to seal off those tubules. They'll create tertiary or reparative dentine. So if the fracture is already older, there's not really a need for us to seal that with sealant because the odontoblasts will probably have sealed it themselves already. So as long as that tooth x-ray is okay, there's probably no reason for us to follow it up. But if it's a recent fracture or it's the first time we've come across it, then it is worth radiographically monitoring it, because a lot of these changes that we associate with pulp death or pulp inflammation don't become obvious until several months later. So one of the things we look at is that the pulp space in these teeth that have died will be wider than the teeth that have continued to develop because the tooth stopped developing. But if the fracture happened yesterday or the trauma happened yesterday, you're not going to see that difference in scale. So you need to wait a few months for the other teeth to continue to developing before you can see that. For these periapical lesions to become visible on X-ray, we need to lose at least 30 to 40% of the bone density. So that's not going to happen overnight. So again, those are things that take time for us to be able to see on X-ray. So if we can't see them on the day and it's a recent fracture or it's the first time we've picked it up, it's worth recommending a repeat set of X-rays the next time that animal is in. There's a special type of uncomplicated crown fracture that we call a near pulp exposure. And these are the ones where you cannot enter the pulp space with your explorer, but you can see this pinkish sheen through the dentine. And when you can see that pinkish sheen of the pulp, it means that there's less than a millimeter of dentine between the outside world and the pulp below. That's why we're able to see it shine through the dentine. In principle, nearly all cat fractures of their canines are either complicated crown fractures or near pulp exposures. And this is because in cats, the pulp extends extremely far into the tip of the canine teeth, particularly the maxillary canine teeth, and they only have about 1 to 2 millimeters of overlying dentine to begin with. So as soon as they fracture off a bit of that dentine, even if it's just 1.5 millimeters, they already have a near pulp exposure. And the problem with near pulp exposures is, again, those dentinal tubules. The closer to the pulp we get, the more of the tubules per square centimetre are present, and the bigger those tubules are. So when we're that close to the pulp, there's a very short distance that bacteria will have to get through to get into the pulp, and there's much more opportunity for them to do so. That's part of the reason. And also the pulp being that close to the open world, it's going to be exposed to a lot more irritants in our food, irritants in the things that we drink as humans, and painful reactions. So we're going to get a lot more inflammation of the pulp as a result anyway. And that inflammation has the potential to lead to chronic or fatal damage to the pulp. But in general, any tooth with a near pulp exposure, we treat like a complicated crown fracture. And that's the next one we have, which is the CCF, complicated crown fracture. And the reason we call it complicated is because, as we can see on this picture, we have entered the pulp space at this point. And unfortunately, because a tooth really only is in connection with the rest of the body through the little apical delta at the apex, it's very difficult for the immune system to be able to get all the way up to the top of the tooth where bacteria from the mouth are now ingressing into the tooth. And the pulp tissue itself is exactly what bacteria love to proliferate on. It's serum rich, it's nutrient rich, it's warm, it's moist. Bacteria will get in there straight away. They will colonize part of the pulp, they will kill part of the pulp, and then they will move on to the next bit of the pulp, the next bit, until the entire pulp is dead. If we have a complicated crown fracture in a deciduous tooth like this one is, then extraction is always indicated. It is nearly never proper for us to wait for that tooth to exfoliate on its own. And that's because the process of exfoliation of the deciduous tooth or the baby tooth happens because there is a different set of triggers that are initiated that will instigate resorption of the root of that tooth so that only the crown portion is left. And then when the adult tooth starts to erupt, it pushes the crown portion off. But because in these teeth, the pulp is dead, a lot of those triggers don't occur. So it's very common that these teeth will not shed normally, which means, especially in the canine teeth, that they can result in malocclusions and eruption in the wrong place of the adult canine teeth, which then will need more treatment. But they are also a massive source of infection. And this is a small Cocker Spaniel that I saw as an emergency over the weekend when I was at Eastcott, because she had fractured this tooth about 2 weeks prior to me seeing her. Unfortunately, her vets said, it will fall out naturally, we'll just monitor it. And within the 2 weeks, you can see how grey and disgusting the pulp has gone. We've got a draining tract at the height of the mucogingival junction behind that tooth. And the reason I saw her as an emergency was because the whole right side of her face blew up like a balloon. She got massive cellulitis associated with it too, and went off her food acutely. The amount of inflammation that can be associated with these deciduous teeth if they're fractured also puts the developing adult tooth at risk. So the adult canine is right below this tooth. It's developing its enamel and its crown portion around this age. And if we have a large area of localized inflammation, that can cause deficits in the enamel formation, and we can end up with a tooth that's malformed or has enamel dysplasia or hyperplasia in localized places. And then again, that tooth may well need more treatment, or in a very, very worst case scenario, could potentially not erupt and need extraction later down the road. So really, unless the tooth was going to fall out 2 days from now, I would always recommend extracting these teeth because they are a massive source of infection, and they're also really painful. But puppies are really, really dumb, and they are really bad at showing pain, of oral pain of any kind. They're way too distracted by everything else that's going on in the mouth. If it is an adult tooth, but it's an immature tooth, then part of our problem is that the way we want to treat a complicated crown fracture is by removing the pulp that is infected. So with immature teeth, Ideally, we want to get there as soon as the trauma has occurred or as quickly as possible, because by that point, the infection hasn't gone all the way down into the pulp yet. We can remove part of the pulp, and then we can do a treatment called direct pulp capping or vital pulp therapy, where we apply a dressing material called MTA directly onto the pulp, and then we put a filling on that tooth. And the idea behind that treatment is that it will hopefully allow the pulp to get on top of the insult that has occurred and will keep the pulp alive and therefore keep the tooth developing over time. So therefore, we want to see these guys as quickly as possible, and they constitute another of those true dental emergencies. Overall, the success rate of vital pulp therapy is about 80%. From human dentistry, we know that the prognosis improves the quicker that we can see these patients, but there's not enough information and literature available in veterinary dentistry for us to really know like exact timings and exact prognosis per time. But ideally, we want to see these on the same day or the day after it happened, potentially all the way up to a week after it happened. We can still perform the treatment like a week to 10 days after this has happened, but we will be cautious with telling the owner that it does need follow-up. It's more likely to fail. We really need to keep an eye on it. It can still be of benefit to perform this treatment though, because we might still buy ourselves some time. And in buying time, we might allow the tooth to develop enough for us to be able to perform a root canal later down the line. If the trauma is older, then we're probably likely to recommend extraction. But if the owners, again, are really motivated and they really want to keep the tooth, then there are treatments that we can attempt to get that tooth into a better place. And the reason that treatment of these teeth is really difficult is because their dentin walls are so thin. So if we cannot get the tooth to develop any further, not only do we not have a fully formed root, but we have a tooth that will remain very, very fragile throughout its entire life and be very, very prone to things like root fractures. So we can perform a treatment called apexification. This is where we pack the entire cavity of the tooth with a dressing material called calcium hydroxide, and we refresh this on a regular basis, so every couple of weeks. And calcium hydroxide is an antimicrobial type of substance, so it's going to continue to disinfect the canal, but it also instigates cells in the area of where the root apex would normally be formed to create a substance that's similar to dentine and create the rest of the root apex. So then we're creating something that we can backfill against, and we can then perform a root canal on. But a really exciting part of endodontics that they do more in human medicine, but we also do have protocols for it in veterinary medicine as well, is something called regenerative endodontics, and that's making use of that clump of stem cells that I mentioned earlier. So what we do there is a specific set of procedures where we both disinfect the tooth, and then once we're happy that that tooth is clean and disinfected, we will then initiate bleeding at the bottom of the canal, and this will bring in a rush of growth factors and lots and lots and lots of stem cells into the whole tooth. And the idea is that from those stem cells and growth factors, the pulp itself can actually regenerate, and we can grow a whole new pulp, and the tooth can continue to develop. So it's very exciting, but it's quite a lot for an owner to commit to, and it's therefore rare that we end up doing that. But I do find the idea of it very, very exciting. When we talk about mature teeth, though, really the easiest option for maintaining the tooth is going to be root canal treatment. And the reason for that is because the success rate of root canals is really quite high. It needs a lot less follow-up than vital pulp therapy. It's a lot less of a step-by-step treatment than apexification or regenerative endodontics. And in the right hands, it's a relatively routine, straightforward procedure to perform, although it's very tactile, it's very step sensitive. But it is also a really, really fun part of being a dentist to do root canals. And basically what we're doing here is we're removing all of that infected and necrotic pulp, we're disinfecting the canal, and then we're replacing the pulp with an inert material called gutta perca. And then we're sealing that whole canal off from the outside world. So we're placing a restoration on the crown portion to seal that off from the mouth, and the gutta perca itself is sealing the apex off, so that seals the chamber itself off from the rest of the body. So we've already disinfected the canal, but that way we're ensuring that any potential bacteria that are left in the tooth never come into contact with the rest of the body again. So that's a really fun treatment to do. If the fracture extends down into the root as well, so it involves both the crown and the root, we talk about a crown root fracture. And these can be a little bit more complicated, and it really depends on how far the fracture extends down into the root space. If the fracture is quite superficial, we can perform something called a crown lengthening procedure. And the reason we want to do this is because where the fracture extends under the surface of the gingiva into the root, that fragment that's been removed would have also contained the surface that had the cementum on it that the periodontal ligament could attach to. And in removing that, we've now created that fracture surface, and the periodontal ligament cannot attach directly onto that surface because there's no cementum there, and the cementum cannot form directly on that. So in essence, as the gingiva around that tooth heals, we've created, or what has happened is the creation of almost like a false periodontal pocket. We've got a pocket that plaque and tartar can get adhered in. That's already predisposed to the development of periodontal disease. And that particularly becomes a problem when the fracture extends into a furcation area as well, because then we not only just having a periodontal pocket that's been created, but we also have furcation exposure. And both of those things are already placing that tooth in a higher category of periodontal disease, moving it towards the point of no return where we have to extract it. But if the thing is very superficial, we can do what we call a crown lengthening procedure. And basically what we're doing here is we're exposing the entire fracture surface to the oral cavity, that we're keeping the depth of the gingival sulcus in the pocket a normal depth. And that can be quite an easy procedure. So sometimes it just, if it's very superficial, it just is a little gingivectomy or gingivoplasty. We need to maintain about 2 millimeters at least height of the gingiva from the mucogingival junction. So you do need to have enough gingiva present to be able to do that, but it can sometimes be as simple as that. However, sometimes we do need to do what we call a class 2 lengthening. So this is a Staffordshire Bull Terrier where the owner was very adamant they wanted to keep the teeth, even though there's not a lot of tooth left there. So what we do in this case is, unfortunately, we did need to extract the first premolar because it had a root fracture, and we need to extract the third incisor to create space for our crown lengthening procedure. We then create this flap, and we recontour the bone around the tooth. On each side of the tooth, we've removed bone height, and then we've recontoured the edge of the bone to kind of come up towards the tooth in a physiological way. And then we've sutured the gum back into place. And you can see as we've sutured it, it's now moved downwards because it's sutured. It's now lying flat against the bone that we've also brought down. And that's exposed the fracture surface to the rest of the mouth. This tooth had a root canal done on it in the meantime as well. And this is what it looked like at the 6-month follow-up. So you can see the gingiva is all healed very nicely. The whole fracture surface is still exposed to the mouth. And we've got very minimal inflammation of the gingiva around that tooth, and certainly no abnormal pocketing. So in some cases, if we are able to do these kind of procedures, and the owner is willing to follow that up and keep it really healthy and brush it and keep it clean and come for follow-ups, then there are ways that we can maintain these pieces of tooth and prevent us from having to do a big surgical extraction. However, in the majority of cases, especially when it comes to fourth premolars, where these kind of slab fractures are really, really common, extraction is much more likely going to be indicated. A lot more of these teeth are unfortunately what I would term a write-off, as with this one. And these type of fractures are different to the ones that we see on canines, because canines often break because they have a force applied to them from the side. So they're bending in a way and then snapping. Whereas carnassials, the top carnassial and the bottom carnassial, are designed to slide past one another like a pair of scissors. So if dogs put something between their teeth that's really hard and try and chew down on it, they push the tip of the upper carnassial outwards towards the cheek, and they push the tip of the bottom carnassial inwards towards the tongue, and that's how we get these snap slab fractures occur. And sometimes they can be really obvious, like this one. Sometimes they can be really subtle or hidden by a lot of tartar. And they have these loose fragments that you can often just pick up with on your nails and make them move. So if you ever see an unusual amount of tartar accumulated on that tooth and the tooth is a slightly abnormal shape, it's worth just giving it a little bit of a feel with your thumbnail if the animal will allow, just to see and make sure that we don't have those kind of slab fractures quite obviously present. Then, as a final type of fracture, we have our root fractures, and a lot has changed in the opinions on root fractures and their treatability throughout the years. But generally, if we can manage to reposition the tooth and get the two edges of the root back together in a normal position and then splint the tooth, normally the prognosis is pretty good for those, irrelevant of at what height in the root the fracture is. The exception to that is if the fracture is really high up in the tooth, so at the level of the alveolar bone or above that, so really almost exactly where the crown meets the root. If the tooth is fractured there, then there's not really an ability for us to reposition that properly and get it to heal, because a lot of the healing that occurs in a root fracture happens because we get nutrient supply and blood supply and cell supply from the periodontal ligament space and the alveolar bone around it. So if the fracture is too high, we don't get those things that we need to allow the root to heal. And that healing can occur in different ways. Sometimes you get it healed with tooth substance, sometimes it heals with soft tissue in between, sometimes it heals with bone in between, but we can often stabilize that tooth and keep it quite healthy. It is important that we radiographically monitor those, to see that it's healed properly, but also because death of the pulp does occur, not actually in all cases. So if we can position it nicely, the pulp can often regenerate itself where it's touching because it's still getting the blood supply from the apex. It's just been cut off in the middle. So if we can bring those in approximation, you should get new vasculature bridging that gap. But in about a quarter of the cases, we will get necrosis of a portion of the pulp. And if that happens in the more coronal portion, we can do a root canal on the more coronal portion. If it happens in the apical portion of the root, then we can do something called an apicectomy, and we can remove that apical portion of the root and just leave the rest of the tooth in place. And then the final thing, type of TDI that I'd like to talk about is the non-vital tooth. So we looked at an X-ray earlier of a tooth that had undergone a concussion injury potentially, or a subluxation. So definitely not a tooth that has displaced from its socket at all or has a obvious fracture to the crown, but this is a tooth that has undergone some sort of blunt force trauma, and it has, as a result, discolored. This one's purple, but sometimes they are more yellowish, sometimes they are more grey. It depends on how recent the trauma was and the individual, really. And sometimes they're not fully discolored like this one. Sometimes there's only partial discoloration. But basically, that discoloration is an indication that the pulp has swollen. And when the pulp swells inside the pulp chamber, because it wants to swell when it gets blunt trauma, like any soft tissue would, it can't swell very well because it's encased within hard tissue. And as a result, it will leak blood products into that tubular dentine, and that stains the dentine. And that's why these teeth end up becoming discolored. So it's an indication that we've had swelling and inflammation of the pulp. And when a pulp undergoes blood trauma like that, it can then either get on top of that and it can heal properly, and it can just go on to lead a normal pulp life. The discoloration of the tooth will be permanent, however, or it can undergo something called irreversible pulpitis, and that's where this inflammation just constantly keeps on going, and that's often because small portions of the pulp have succumbed to the swelling and inflammation and have died off. And those then act as little niduses of continued inflammation. And that continued inflammation can eventually lead to death of the pulp entirely. Generally, any discoloration of the tooth like this has a reasonably poor prognosis for the tooth. So we know from histological studies that 87% of all discolored teeth are not vital anymore. That's a huge amount. But even if we looked at the teeth that were still vital in histology, 25% of those had active pulpitis going on and therefore still have the potential to progress on to pulp necrosis. Partially discolored teeth possibly have a slightly better prognosis. However, 62% of them would still be non-vital. So it's not 87, but it's still nearly 2/3. And of the ones that were vital, 40% of them had active pulpitis and therefore have the potential to progress to pulp necrosis. So really, any discoloration of the teeth should prompt us to treatment rather than monitoring, in my opinion, because just the vast majority of these teeth are going to have either ongoing chronic pulpitis, which is uncomfortable, and the vast majority of them are going to end up dying and becoming necrotic pulp. And really, when a pulp is necrotic like that, it is going to lead to problems. It's not a question of if it's going to, the question is when. So in that case, it doesn't really make any sense for us to say things like, oh, well, it's not bothering the dog now, so we'll just wait. Because if the dog's healthy now, why wouldn't we just treat it now and prevent it from becoming a problem rather than wait for it to become a massive problem? And then the dog's in pain. It's maybe has other comorbidities because it's now older. And now, because we have all of that information, maybe the tooth is so damaged that we now have to extract it. We don't have any other choice. So if we can be proactive about these things, we can actually gain a lot of comfort for our patients. I think there's also a misunderstanding that teeth that are necrotic and dead don't have any feeling. I'm having broken my tooth myself and then walked around with it for a year. I did not do this as an experiment. Much as I love veterinary dentistry, I'm absolutely terrified of going to the human dentist. So I just didn't go for a whole year. And although my pulp became extremely necrotic because I had a complicated crown fracture, every time I drank or ate something that was cold or hot, that tooth was excruciating. I retaught myself how to drink and eat in a way that it didn't touch that tooth. It's not painful all the time, but it still really alters the way I was doing things on a day-to-day basis. And I'm sure that it does in our patients as well. They're just very, very good at hiding it. So I think this is one of those things where we can really advocate for our patients and really be their voice. Our treatment options for these teeth are extraction, root canal treatment, or if the owner is really hesitant to go for one or the other, there is a percentage of these teeth that will be fine, then radiographic monitoring could also be an option. I would recommend radiographic monitoring because that is an objective thing that we can use to measure the changes in the tooth, whereas waiting for the dog to express pain or waiting for the tooth to become an abscess is leaving our patients with potential discomfort for a prolonged amount of time. Whereas taking dental x-rays can be done under a very, very light anesthetic and takes a mere few minutes. That covers all of what we would normally class under TDIs. And before we finish up for this evening, I just wanted to touch on two other types of injuries that we can see to the teeth that are really important for us to also not just sweep under the rug as something that's not a problem because the pulp's not necessarily exposed. The first one is abrasion. And abrasion is defined as wear of the tooth because it's come into contact with an abrasive substance outside the mouth. So a really common one is tennis balls. Tennis balls have that fluff on them, and when they get wet with dog saliva, they get sand in them. They basically act like sandpaper, and they can wear through a tooth really quickly, especially if dogs are really obsessed with them. This boy not only loves tennis balls, but also loves to dive into rivers and bring up bricks and dig boulders out of the side of the river. So also stone chewer and has worn his teeth down really well on that. And if that wear happens at a reasonably slow rate, or at least at a rate that the tooth can maintain, The layer of odontoblasts within the pulp chamber will create tertiary dentine or reparative dentine as the tooth is wearing down, and they will maintain a minimum amount of dentine between the outside world and the pulp space. So in essence, the pulp will retract away from the surface of wear as a way of protecting itself. That tertiary dentine that's formed in a structure-wise is a little bit more haphazard in structure than the bulk structure of the tooth, and therefore it's more prone to staining. So it will very often show up as a dark brown circle in the middle of the tooth. But if you run your Sharp Explorer over it, then it should feel really smooth on the surface. It shouldn't catch on anything. We often will describe it as going over glass. However, if the wear happens fast enough, it can outstrip the ability of the odontoblast to keep up with dentine production. And then we do end up getting irritation and death of the pulp. And then eventually, as the tooth wear continues, we will open up that pulp space. And that's what we can see has happened to this boy here on his lower left canine tooth and his second premolar tooth. You can see that on all his other worn teeth, it's difficult to see the center of it, but he's got like a slightly more yellowish circle in the middle where he's got tertiary dentine. But on these teeth, he's got this black hole. And if you run your Sharp Explorer over that, it will catch in the hole. I have seen that some people have done this on animals when they're awake. I really recommend not doing that because, as I said before, even though the pulp is necrotic, somehow there is still feeling in that pulp. And if the pulp isn't completely dead yet, that putting a Sharp Explorer into a hole like that can be extremely painful and definitely risks people getting bitten. So this is the type of exploration that if we have the feeling that that is an open hole, then we need to explore that under anesthetic. And if it is open, then we need to treat that appropriately. This boy had extreme sensitivity with cold water. So anytime he would drink cold water, he'd pour at his face aggressively. And that's because this canine tooth had been dead for years. And it had a huge periapical abscess. I didn't even have to raise a flap for this tooth. I extracted it in a closed manner, and then there was a huge cavity full of pus right behind it. Even though the gingiva around it was intact, the whole root end was coated in tartar. So that all those bacteria from the mouth had gotten down into the canal and infected the root, and then caused a really deep bone infection. So he's bound to feel a lot more comfortable now that that tooth is gone. But it just goes to show how careful we need to be with picking up this kind of wear early on and being able to advise owners to try and avoid those kind of activities. Another type of abrasion that we kind of commonly see, especially with working dogs or dogs that are kennelled a lot, is what we call this cage biter abrasion. So this is where dogs they'll hook their canines over the bars of the cage, and then they're pulling at the cage or they're biting at the cage, often because they're bored or frustrated. And if that is the case and there's no way to keep them from being kennelled, so this is a military police dog, so he lives in kennels. Then one of the advice that we can give there is to change the kennel setup, so they can add soft coatings to the bars to help protect from that abrasion. In this case, this boy had quite a severe abrasion. It was quite high risk of fracture. He ended up getting a composite restoration of that and a crown to prevent further wear from occurring as well, because he was quite an important dog. Then the next type of wear we have is attrition. And attrition abrasion are often confused because the words are really, really similar. The way I remember it is attrition has two T's at the beginning, and it has two T's because it's a tooth on tooth type of wear. So it happens when teeth have an abnormal contact. So it's really common in dogs with malocclusions, especially in our brachycephalic breeds, because they have a very tight occlusion because all their teeth are kind of trying to fit in their really short muzzles, and especially if they've got an underbite, so class 3 malocclusion as well. So this is a Staffordshire Bull Terrier, and we can see here that the occlusion of the canine teeth is too tight. So when this dog closes his mouth, his mandibular canine is rubbing up against his maxillary canine, and it's creating this large wear facet. And where we're getting exposure of the dentine, we've had tertiary dentine that's been created by the odontoblast, and that tertiary dentine has stained brown. So we can see that at some point we have, this wear has been like this whole dog's life. So when this dog was young, this facet of wear was already close to the pulp space. If you pick this up in quite an old dog, it's very likely that the wear has occurred to a level where the teeth aren't in contact anymore, and it probably won't need any treatment. But if it's a young dog, we can alter the shape of the teeth so that they don't come into contact with each other anymore, because this continued wear puts a lot of stress on the odontoblast, puts a lot of stress on the pulp. It's a type of repetitive concussive trauma to the tooth as well, so it can result in pulpitis and death of the pulp as well. So if we can pick it up early enough, there are very easy things that we can do to make these patients more comfortable as well. This is a really kind of obvious area of attrition to find, but a very secret one is in those dogs that have a class 3 malocclusion, so they've got an underbite, are these wear facets that occur right on the lingual side, on the distal edge of the mandibular canine. And this is when the dog closes their mouth, their second or third incisor will rub against the canine tooth and cause this wear. And you can see how this has caused a local area of gum recession. So if this keeps happening and we keep getting this localized trauma, not only are we causing damage to the actual root of the tooth, we're predisposing that tooth to periodontal disease, because the gingival sulcus is getting damaged every single time that dog closes its mouth. It's not quite clear in this photo, but it's really common as well that the first and second incisors of these dogs will press into the soft tissues just behind the bottom incisors, and you'll have little trauma injuries to the soft tissues of the mandible as well. And those are things that can be very easily treated by extraction of the maxillary incisors, because that can be a very long, ongoing, painful thing. And depending on how severe their underbite is, it can actually cause quite significant trauma to the mandibular incisors as well, and then lead to loss of both sets of teeth in the long run. So I wanted to give you all guys that one as just an additional little type of TDI. It's not in the official list, but it's just another thing that we need to keep an eye out for, and that can sometimes be quite subtle. So to round it up for the evening, my take-home messages for today for you is always be on the look for traumatic dental injuries, because you're going to find more the more you look for them, and that kind of goes for everything in dentistry. Know what to look for. Remember all the different types of injuries that we see, but specifically there's little types of uncomplicated crown fractures, additional mobility, wear, attrition, abrasion, and be thorough. A lot of the time when we're looking at a dog's mouth, we just lift up the sides and we look at the amount of calculus and gingivitis that's on the side, but we forget to look at the tips of the canines, the tips of the incisors. Cats, for all of the grace that we attribute to them, are very front heavy, and it's really common that they fall on their face. So tiny tip fractures of the canines, extremely common. Missing incisors with no history of extraction almost always are fractured incisors. So look for these things. If you know that they're there, you'll find them much more often just because you're actually looking in the right places. Remember that some of the things that we've talked about today are considered true dental emergencies. So if you see them, don't hesitate. We're a very, very friendly bunch, us dentists. And if we can come to the phone, if we're not in the middle of doing a procedure ourselves with a patient under anaesthetic, we're always more than happy to come to the phone for these kind of things. And we will always do our best to try and fit these kind of patients in, because we know how important it is that they get seen ASAP. So remember, our luxation and avulsion, if the owner wants to maintain the tooth, absolutely needs to be seen, ideally for avulsion within 3 hours in the right medium, luxation within 24 hours. Some are not emergencies, but are truly urgent. And these are complicated fractures in immature teeth, again, where they want to keep the tooth. If it's a recent fracture, we can do a vital pulp therapy, and that's the nicest treatment because we can keep the tooth developing in a normal way. But we want to see it as soon as possible, not weeks after the fact. And remember that even teeth with no pulp exposure still need to be checked, because there is always a chance that we could have significant endodontic disease present. And if you can only remember those things from what I've said this evening, I will be an extremely, extremely happy dentist. It's not just me. As I said, teamwork makes the dream work. And we've put on this webinar today as part of a 2-lecture series. So next month, on the 6th of November, my fantastic colleague Jess will be doing an in-person event here at Fitzpatrick. So unlike this webinar, This one will actually be at the practice, so it'll be lovely to see some of you there and meet you all. And Jeff will be talking about nursing management of facial trauma patients. So we're staying within that trauma, but we're going a little beyond the piece now. And this will consider for the facial trauma patient all the way from when they first present all the way up to their discharge, so including what to consider about initial stabilization of these facial trauma patients, what considerations we need to take when we're anesthetizing them, some of the different treatments that we very commonly will use within our maxillofacial surgery department, how to take care of the patients while they're in the hospital, and how to both take care and maintain their tube feeding while they're here, but also communicate that and get owners prepared for potentially continuing that tube feeding at home. So it's a lot of stuff to put in one lecture, but it's bound to be a really interesting evening. And I hopefully look forward to seeing lots of you there. The QR code is there if you guys want to scan. In the meantime, I'm happy to take any questions. If anyone's got any, just pop them in the chat, and then I will take them from there. So I'll give you guys a few minutes. I've not had any questions come up in the chat, so I just wanted to take a short moment just to thank all of you for coming out this evening. I know we've got loads of participants, not just from the UK, but all over the world, which warms my heart as someone who's been quite international themselves as well. So it's been lovely to see you all, lovely to meet you all, and I really look forward to meeting some of you guys next month for Jess's lecture, and otherwise seeing you guys back anytime we put on another webinar. Thank you very much, guys, and have a lovely evening.